Good afternoon, everyone. My name is Joshua Berry, and I am the Health Promotion and Disease Prevention Analyst at ASTHO, the Association of State and Territorial Health Officials. I am honored to welcome you to this webinar on behalf of the Tobacco Control Network. We are looking forward to the rich information and your questions on today's webinar, Communicating Challenging Tobacco Control Policies with Executive Leadership. Before we get started, I'd like to overview the logistics for this afternoon's webinar. You'll have the option of listening to this webinar through your computer speakers, which is the preferred method, or over the phone through the toll-free number and passcode shown on your screen. Please do not use both methods to avoid feedback. This webinar is currently being recorded, and a link to the recording and webinar slides will be sent to you via email soon after the recording is available. The recording and webinar slides will also be posted on the ASTHO and TCN websites in approximately 2 weeks. We invite you to participate in this afternoon's question and answer session by typing your questions into the on-screen chat box at any time during the webinar. Computer and phone lines will be muted for the duration of the webinar. So as you see, we have a full agenda to cover, and we also have a number of meeting objectives. And our goals on this webinar are to 1, identify best practices to address emerging and challenging areas in tobacco control policy implementation. 2, to understand how to engage state health department executive leadership to address these challenges in tobacco control and cessation. And 3, to share resources that can be used by other health departments and stakeholders interested in implementing challenging tobacco control policies and measures. So a little bit about ASTHO. ASTHO is the national nonprofit organization representing public health agencies in the United States, the U.S. territories, and the District of Columbia, and over 100,000 public health professionals that these agencies employ. The Tobacco Control Network, or the TCN, is an ASTHO peer group, which is chaired by Barry Sharp from the Texas Department of State Health Services, and is comprised of the Tobacco Control Program Managers, additional tobacco control programs, such as the Funders Alliance, and additional staff from each state, territory, and DC. The partnership between ASTHO and the TCN provides a valuable linkage to tobacco programs across the nation and assists ASTHO in achieving the goals of tobacco prevention and control with an accurate state-level perspective. And as you see here, we have the TCN Executive Committee chaired by Barry Sharp, with a diverse representation from around the United States. And with that, I would like to give the floor to the presenters joining us today for today's webinar. Starting us off is Laura Olivan, who serves as the Tobacco Control Manager for the Minnesota Department of Health in the Office of Statewide Health Improvement Initiatives. Laura has been working to promote healthy communities at the local, state, and federal level for over 20 years, and she holds a Master of Public Policy from Georgetown University. Laura, please go ahead and get us started.
Thank you, Josh. It's my pleasure today to share with you the Minnesota Department of Health menthol, tobacco, and health equity work. Today we're going to highlight the steps we've taken to communicate these issues to health officials. We have found that in working on advanced policy, it's most effective to roll it out in stages. Today we're going to cover our community input, data analysis, the research we've done, the statewide planning we've documented, our menthol grant making, our media work, and the community engagement around menthol. So in Minnesota, our adult and youth rates are at historically low levels, but as you can see, serious disparities continue to exist among certain racial, ethnic, and economic groups. So MDH is committed to addressing these health inequities, and in doing so, we take a triple aim approach. This is also part of Dr. Ellinger's ASTHO Presidential Challenge. So at MDH, we're redefining our understanding of what creates health to include factors like socioeconomic status, transportation, and housing. We are expanding our definition of what constitutes health into other policy areas beyond the traditional scope of public health. And an area where we're most focused here in tobacco control is we're creating new mechanism and funding strategies to strengthen the capacity of communities to create their own healthy futures. It's been an exciting year here at MDH, and to further our understanding around health equity, we undertook a statewide community input process and convened 17 in-person meetings throughout the state, talking with a total of 350 participants. We really focused on the populations most disparately impacted by tobacco. Through these direct conversations, we gained new insights on the needs and strengths of the community, and we'll be issuing that report shortly on our MDH website. One of the things we learned in talking with these different population groups is the pervasiveness of smoking norms in some communities. This was especially true around menthol tobacco use. At the same time, MDH partnered with fellow Minnesota tobacco prevention funders, Clearway Minnesota and Blue Cross and Blue Shield of Minnesota. We convened a 28-person advisory committee to create a 5-year comprehensive tobacco control framework. Any of the CDC tobacco control managers on the phone today will recognize this as one of our core plan requirements. And it was a fabulous experience here in Minnesota. And Andrea Mowry, the incoming president for ASTHO, was a co-chair with me in developing this framework. So in setting our vision for a Minnesota where all people are free from the harms of tobacco, we developed 17 bold steps. One of the bold steps is specifically to restrict sales of menthol-flavored tobacco to adult-only tobacco stores. You can now find the framework on our MDH website, and I encourage all of you to look through that document. So in Minnesota, we're helping lead the nation on advanced tobacco control policy. In the last year, both Minneapolis and St. Paul have now limited the sale of all flavored tobacco to adult-only establishments, removing flavored tobacco, including flavored e-cigarettes, out of retail stores where kids shop every day. We can now turn our attention to the harms of menthol tobacco. Minnesota's data mirrors national figures showing significant disparities in tobacco use, particularly around the use of menthol cigarettes. Nearly half of our high school smokers use menthol. This number has almost doubled in the last 10 years. In Minnesota, a whopping 74% of adult African American smokers choose menthol cigarettes. This is especially concerning because African Americans are 36% more likely to die of lung cancer and 53% more likely to die of heart disease than their non-Latino white counterparts. So, in our role as Public Health Authority, MDH commissioned a comprehensive review of the latest research on the health risks of menthol tobacco, and we issued a new MDH menthol fact sheet, which is available on our website. We distributed it widely to our extensive network of grantees and have trained on it. And this also ensures that all of us, all grantees at the local and we at the state, are using a consistent set of facts and data to talk about the health risks of menthol. Our fact sheet notes that a large number of studies show that menthol users have a higher nicotine dependence and smoking urge. Menthol users have a harder time quitting than non-menthol users. This finding is stronger among African American and other minority populations than among white smokers. We've also documented that menthol cigarette marketing has targeted more young people and African Americans than other groups, resulting in significantly higher smoking rates. For us, this research really came alive in the community input process that I mentioned before, when one African American stakeholder had this to say on menthol. Menthol, they've targeted us, and we didn't even know we were under attack. I remember as a kid wanting cool cigarettes because they were cool. They were trying to addict us to these cigarettes, but the same thing was not happening in other communities. In 2015, the Minnesota State Legislature wanted to highlight the risk of menthol tobacco on the African American population. A bill that started out as a MDH research report turned into a required menthol grant program by the end of the legislative session. The state required us to issue a 2-year grant to, I quote, engage members of the African American community and community-based organizations to implement strategies and interventions to reduce the disproportionately high usage of cigarettes by African Americans, especially the use of menthol-flavored cigarettes. So I'm pleased to say the grant is now underway, and the local public health authorities and the African American community-based organization we funded are currently in the assessment and information gathering phase. They have over 2 years to produce the deliverables. Our partner organizations have also launched a menthol coalition to further mobilize and engage the community. You know, we're very lucky here in Minnesota to have other menthol and tobacco funders in the state. So our partner, Clearway Minnesota, recently launched a new menthol tobacco campaign. Here is their print ad. This week, they're also launching a new set of television ads, which can be found on YouTube, if you'd like, by searching Bad Relationship by Clearway. It's excellent, and it highlights the addictive impact of menthol on youth. So in summary, the strategies we have successfully used to communicate the health risks of menthol tobacco to our health officials are developing data to document the problem, listening and documenting community voices with direct experience with menthol tobacco, issuing research and data on the problem in the form of fact sheets and other public health tools, collectively defining the bold steps, including menthol, in our state framework, issuing local grants to fund community-level engagement and develop community-driven solutions, and finally, to launch a creative and earned media campaign. You can find a lot of this information on both our website at MDH and on Clearway, Minnesota, and you can also find our fact sheet on the website. So I thank you very much for this opportunity to share our experience with you today.
Thank you, Laura, so much for a wonderful presentation and getting us started. And so moving right along, on the topic of Tobacco 21, we have joining us Beverly May from the Campaign for Tobacco-Free Kids. Beverly serves as the Regional Advocacy Director for the Western States and the National Project Manager for Raising the Tobacco Age to 21 for the Campaign for Tobacco-Free Kids. She provides support and technical assistance to state tobacco control coalitions and programs as they advocate for tobacco control policies and implement comprehensive tobacco prevention and cessation programs. Beverly has a Bachelor of Science degree in Community Health Education and a Master's in Public Administration from the University of Utah. Beverly, thank you for joining us, and the floor is yours.
Thank you, Josh. Happy Monday, everybody. I wanted to start out saying policy, and all of a sudden it's in no way does this replace what we feel that has always been our, which means a comprehensive state tobacco prevention higher.
Hi, Beverly. This is Josh. I'm not sure if you're coming in clearly. Could you possibly try to speak a bit more clearly into the phone?
I couldn't get any clearer. Let me put it on speaker and see if that helps. How about that?
Yeah, I can hear better. Yeah, please give that another go.
Okay. I'd like to start out by saying that this is an emerging policy that has really taken hold. and it no way replaces what we know that has been effective, which is a comprehensive tobacco prevention and control program for each state. We also know that raising the taxes are very effective. Youth are sensitive to raises in taxes and clean indoor air. This is another tool that we have in our arsenal to move forward with delaying the onset of youth starting to smoke. We know that 95% of adults start smoking before they turn 21. We also know the transition age of smoking, 18 to 21, is a transition age, and we also know from a lot of studies that have come out, and there's more in the pipeline, that the developing brain for a young adolescent, teenager, is very susceptible to nicotine as well as they are to other drugs. So there's more and more scientific-based information that's coming out, which is very critical for any of our organizations because the tobacco industry has their stories and their money, but we want to be science-based with the facts that we give out. Nationally, we know that 18, 20-year-olds are twice as likely as 16 to 17-year-olds to be current smokers. Now, the one thing that I think is really important if you read the quote from Philip Morris is that they were concerned about this back in 1986 because they knew that this was a market of if we would do anything to raise the age, it certainly would go into their profitability, and heaven knows they need to replace smokers that become addicted. Nicotine is addictive, as we know, and as I just talked about, the brain is still in the periods of growth at this time and development, so they're much more susceptible to these effects. The symptoms of dependency we know with nicotine is withdrawal. Tolerance can occur after just a minimal exposure to nicotine. So what we want to make sure is with 21, it's delaying that onset again. 2/3 of the 10th grade students, nearly half of 8th grade students, say that it's easy to get cigarettes. But we also know that retail violation rate is low, so they're getting their cigarettes from other places. Older youth smokers, 18 to 19 years, are a major supplier of cigarettes for younger kids who rely on their friends or their classmates. So with 21, what this does, it gives a period where hopefully that intervention of doing this will keep youth from buying the cigarettes and giving them to the youngest, at least on the schoolyard and what we've been told by teachers on the corner. Usually that's where the kids are going or to some other location. So what we're trying to do is so they do not have the daily contact with the older students. As we know, the tobacco companies target young adults. They target magazine ads. They do it by parties, bar nights. They do all kinds of sponsoring of activities, and they have not stopped doing that regardless of what they try to say. Tobacco, the key messages we use with 21 is tobacco kills more than 480,000 Americans each year. And virtually all those started before they were 21. You know, I've been doing this for over 20-some years, but when I look at that number, I still always think that that's someone's relative. And someone is losing someone to a chronic disease or death because of the smoking. So I think as you're working with educating, whether it be legislators, educating advocates, I think it's really important to stress we're talking about not 480,000. We're talking about each one of those is a relative, a parent. There's someone that's going to have to take care of this person and also mourn the loss of this person. Since tobacco is so harmful, we should do everything we can. This is why we're trying to work on 21 to delay the onset again. And I keep repeating that, but I think this is what the best thing that we can do if we can delay this onset to a later age and they do not pick up the cigarettes. We were very fortunate this last year when the Institute of Medicine released a national report. This national report from the prestigious Institute of Medicine was very important because it talked about substantial improvements in public health that raising the age to 21 would do. It talked about the impacts over the long run, about reducing the smoking rate, reducing smoking-related deaths by 10%. It talks about premature deaths and fewer deaths by lung cancer. That would be 4.2 million fewer years of life lost. I think it's important to understand with this report, this takes a period of time for this to happen, but this gives us science and what we need to be able to talk to people about this particular policy change. Benefits of increasing the sale, we've already talked about. It delays the age when people pick up their first cigarette, and we know that that is important because the longer they go without picking up a tobacco product, the longer it'll be that hopefully they will not start at all. It helps keep that tobacco out of schools, which is critical because as we talked about before, as I said in one of the slides, they are not getting the cigarettes from the stores. They're getting it from other class mates, and so we're feeling that this will put that time there. Young adolescents would have a harder time passing as 21 years old. And the other thing we found out when we passed this in Hawaii was that it simplifies the ID checks for retailers. It's very interesting when you talk to retailers, same thing in California. You know, they may be adverse to this, but simplifying some of the things, it kind of reminded me of the clean indoor air laws when restaurants didn't want to do this, but then when they realized it's better to have a level playing field, the Restaurant Association started to catch on. Well, I think this will be the same way with retailers. The enforcement piece of 21 is critical, and we have been working on it, and shortly anyone that's on Smart Talk or some other listservs, you will be getting a document that Campaign for Tobacco-Free Kids with other organizations have worked on, talking about some of the things to look at for enforcement. It's important to review some of the current laws to identify any weaknesses. Some of these laws have been on the books for a long time. We've learned a lot, so you want to make sure you look at those laws. We want to make sure that it focuses on the seller, not the youth. We do not want penalties for the youth. There was a situation with the Hawaii law that it came down to the waning hours and they wanted to put penalty on youth. The one thing we compromised to is that it would not be a criminal penalty. We do not want youth to have penalties or criminal penalties or have to deal with law enforcement. This is the focus on the seller. So in that particular law, there is a penalty that would be community service or cessation class, but it would not be criminal. Also, designating an enforcement agency for funding for 21 versus 18. It's important to bring these people to the table immediately. Bring law enforcement to the table. In Hawaii, they had the law enforcement, which is a state that has passed 21, had law enforcement at the table from the very beginning. So it wasn't after the fact they talked to law enforcement. So designate a particular group that would be handling the enforcement. Require so many checks that's necessary. Consider the role of licensing as enforcement. Some states and municipalities are looking at licensing to charge a fee for that, which would cover doing stings and checking on age 21. Certainly require the appropriate signage and provide for retail education. All these things we find important that we really didn't do in some of the laws in the beginning. but realize the law is only as good as the enforcement is. Military. The military is an issue that a lot of people thought we would really have problems with. We have found that the military is just as concerned as anyone else about their rising costs of health care. Chronic disease due to smoking is very costly. The second thing is they are really concerned about readiness. They want their soldiers to be ready to go if needed. They also want them to be healthy. They know that tobacco companies like to target the nicotine. Everything applies to military that we've talked about, and the military has been very supportive in the preparedness and the negative impact of tobacco on troops. So we have been very open with the Department of Defense. They have been great to work with as far as putting out more cessation programs, flyers supporting this. Hawaii, all the groups came together and they support the law on military bases. They can't buy 21. Now, they do not have to do that. Each state is different. They can decide what they want to do, but we have been very fortunate that they have been very open to talk to us about this issue and be at the table. Here's one from the Marines. This general talks about the tobacco impairs reaction time and judgment. This is something you wouldn't have seen 15, 20 years ago. But we're seeing more and more of these cessation and quit tobacco and quotes from different armed services. The economy of retailers, there's little effect on tobacco sales and revenue because this population of 18 to 20 is a very small share of the consumption in any given state or municipality. Reductions in smoking initiation and smoking prevalence will be small initially, but then it will grow over time. The money doesn't disappear. If someone's going into a store and they're not buying their cigarettes, they still have that money, and they're still going to be spending it on other things. So the money doesn't go away. It will still go back into the economy. And also we know the reduced tobacco use reduces health care costs, which we know is very high. The resources for 21, we have them. If you haven't been to Campaign for Tobacco Free Kids website, I'm very proud of the website. We have a lot of information about a lot of issues in tobacco, but the 21 issue is in here, and if you need anything, please let us know. You can send an email to someone at CTFK. You can let me know. And I just want to end by saying we are now waiting for Governor Brown in California to sign Tobacco 21. It was given to him on Friday. He has 12 days to sign it. I don't want to jinx anything, but we have heard nothing but he will be signing this bill. So we are waiting at this point to get it done. We have major cities that we have moved forward with, and Chicago. And I just want to end by saying if you have any questions whatsoever, please let us know at Campaign. We're always ready to help. And thank you.
Thank you so much, Beverly, for that very informative presentation. And I think we're all hoping that Governor Brown can act on that soon in California. And so moving right along, next up is Jessica Hyde from the Texas Department of State Health Services. Jessica is a certified health education specialist, and she received her Master of Science in Health Sciences degree at the University of Texas at Tyler, and she currently serves as the Special Populations Coordinator for the Tobacco Prevention and Control Branch at the Texas Department of State Health Services. Jessica, thank you so much for joining us this afternoon.
Hi, thank you, Josh, and good afternoon, everybody. As Josh mentioned, my name is Jessica Hyde, and I am the Special Populations Coordinator for the Tobacco Prevention and Control Branch of the Texas Department of State Health Services. And my job is to view our branch's programmatic activities through a health equity lens to ensure that everyone, everywhere, can access our resources that are available for tobacco prevention and cessation. Next slide, please. So Texas is home to the second largest LGBTQ+ population in the United States. For this presentation, I will be saying LGBT because it is shorter and simpler to say, but please know that I'm referring to the entire spectrum at large. It's estimated that there are more than 629,000 LGBT-identified adults in Texas. We are second to California in terms of number of LGBT adults. Judging by the census data on same-sex households, most LGBT individuals live in or near major metropolitan areas, such as Houston in Harris County, Dallas in Dallas County, Austin in Travis County, San Antonio in Bexar County, and Fort Worth, which is in Tarrant County. But a key point that we have to remember, as well as our partners, stakeholders, and healthcare providers that we try to educate, is that LGBT communities are dispersed throughout the state. They're not just in the metro areas. In fact, we only have 4 out of our 254 counties that have had 0 same-sex households in the 2010 census. And most of those were in the sparsely populated areas of Texas. Next slide, please. So the prevalence of cigarette smoking in Texas has dropped considerably over the years to 14.9% in 2014. In the general population, smoking rates are higher among men at 16.7% compared to women or females at 12.5%. We unfortunately have very limited data at this time for prevalence of smoking among LGBT communities. The 2015 Behavioral Risk Factor Surveillance System, or BRFIS, was the first year that Texas included questions on sexual orientation and gender identity, but we won't have results available until later this year. And so our branch epidemiologist and I had to do some creative thinking, but we found some piecemeal data that at least gives us some idea of what smoking rates look like in these communities. In the 2013 BRFSS, respondents were asked about the sex of their sexual partners in the past year, and this was a part of a set of questions to gauge risk for HIV infection. We compared the response of individuals to current cigarette smoking against those who reported same-sex or bisexual behavior in the past year. So, of course, this is not ideal, as sexual behavior is not synonymous with sexual orientation, and it does not reflect gender identity, but it at least reinforces our hypothesis that smoking rates are probably higher among sexual and gender minorities in Texas. So for all respondents who reported same-sex or bisexual behavior in the past year, the current smoking rate was 25.7%. Prevalence was even higher for women in this group at 27.5%, which is significantly higher than that of heterosexual women at 12.5%. Data were suppressed for men in this data set because of the small sample size, but nationally, LGBT-identified women tend to smoke more than LGBT-identified men, opposite of what is seen in the general population. And the smoking rates for adults in this group from age 18 to 44, their smoking rate was 34.5%, which is significantly higher than heterosexuals in the same age group at 18.4%, so almost double. As you can see in the table, rates of overall tobacco use, to include smokeless tobacco, were elevated for these groups as well. In Texas, the LGBT communities make up about 3% of the total population, but less than 1% of total calls to the quit line, which is a lower proportion than what we would expect based on smoking rates and the typical majority who want to quit. We, of course, want our quit line services to be accessible and seen as inclusive and welcoming to all Texans, so we started putting together a plan to target our outreach efforts to LGBT communities in 2015 rather, or across that year. At about the same time is when marriage equality was being mulled over by the Supreme Court, and this, if you were following the news, you know, was a hot-button topic in Texas. And so we faced some internal issues getting a contract out the door to procure a subject matter expert in LGBT health to help us develop and implement current culturally appropriate outreach strategies. So we had to think creatively about a plan B. And this is when we looked to our colleagues in the TB, HIV, STD, viral hepatitis unit at DSHS. I'm going to call it the HIV STD unit for short. Because in Texas, about 2/3 of new diagnoses in 2012 were among men who have sex with men, and about half of all people living with HIV are men who have sex with men. So the HIV STD unit had already set a precedent for reaching out to the LGBT communities, so it was seen as apropos instead of unusual, as was the case for our chronic disease programs. So this collaboration also makes good public health sense, as it had the potential for twofold benefit for both the LGBT and HIV communities, because smoking rates are also disproportionately high among people living with HIV. From 2014 to 2015, we know that about 1/3 of people living with HIV who received care in Texas reported current smoking. Next slide, please. And this is particularly problematic because people living with HIV who smoke lose more years of life to tobacco use than to HIV infection when controlling for access to treatment. In a 2013 study out of Denmark on the effects of smoking on the life expectancy of people living with HIV for those who have access to treatment, the median life expectancy for the control group in their sample, so uninfected non-smokers, was 83.5 years. The median life expectancy for those living with HIV was 5.1 years lower than that of the control group. For uninfected smokers, it was 8.6 years lower, and for smokers living with HIV, they shaved 20.9 years off the median life expectancy for a life expectancy of 62.6 years. So this is a textbook example of synergy. The collective impact is greater than the sum of its parts, because if you were to add smoking and HIV together, or the years lost to those, it would be 13.7 years. So you can see that there's a bit of a multiplicative effect. And people living with HIV who smoke face additional risks on top of that, on top of what is seen for the general population. Smoking acts as an immunosuppressant, making it even more difficult to fight off opportunistic infections. Smokers living with HIV are more likely to develop other serious illness than those who don't smoke, such as COPD, cardiovascular disease and stroke, and cancer of all sorts of types. And I just learned this recently, that HIV infection is associated with an increased risk of lung cancer on its own, independent of smoking. So smoking just compounds that risk. And smoking can also decrease the effectiveness of antiretroviral therapy and compound its risk of side effects, such as atherosclerosis. And people living with HIV are less likely to adhere to their treatment plans. Next slide. So we being the Tobacco Prevention and Control Branch, worked with the Texas Comprehensive Cancer Control Program and the HIV STD unit at DSHS to develop activities to reduce smoking rates among these communities by promoting utilization of the quit line, either through self or clinician referral. One of our first activities was in April 2015, and this was a mail-out of Ask, Advise, Refer toolkits to more than 350 HIV clinics and direct care providers across the state of Texas. The great thing about this toolkit that we have is that the material can be added to increase its relevance by specialty. So in this case, we added a one-page fact sheet on the risks of tobacco use for people living with HIV and what healthcare providers can do to decrease smoking rates among their client population. And the toolkit seemed to be very well received by clinicians. We received requests out of Dallas for 160 additional toolkits for clinic employees and a Ryan White advisory board. To supplement the mass distribution of toolkits, we also hosted, along with the Tobacco Research and Evaluation team at UT Austin, a live webinar training in May 2015 to review the toolkit content, provide additional information on quitline referral methods, and provide more information on tobacco education centered around issues for people living with HIV. The Texas-Oklahoma AIDS Education and Training Center helped us spread the word about the webinar by placing the registration link and a digital copy of the toolkit on their website and promoted the webinar through their listserv. And we received overwhelmingly positive feedback from the webinar as well. About 81% of the attendees indicated that they planned on making changes to their practice or service setting as a result of the webinar. In December 2015, we developed a needs assessment that was sent out to a sample of HIV direct care providers and public health personnel just to get an idea of what the perceived barriers to screening for tobacco use at every visit, advising patients to quit, and referring patients to the quit line are. Common barriers were, of course, the usual ones, time constraints, lack of interest or willingness among the patient population to quit. But the interesting one was lack of relevance to scope or practice. And we also found out that about 76% of the sampled have never submitted a quit line referral. And so it's either because they don't know what the quit line is or because they don't know how to connect their patients directly beyond handing them the number to call on their own. So now we know how we can tailor our technical assistance for these providers. Our outreach activities also expanded through to the public through our Cigarettes Are My Greatest Enemy ad campaign that targets seropositive smokers, and it has a very poignant message. It might be a little difficult to read on the screen, but it says, "I didn't survive HIV to die of lung cancer. I had to stop smoking." And it's a message of empowerment that wraps HIV, tobacco use, and cancer, which is the subject matter of our 3 programs working together at DSHS, in a nice, neat little bow. And this is one of 8 ads that address smoking in the context of areas of high concern for LGBT communities. And you can see these at the LGBT Health Link website. We rebranded the ad with Texas-specific quit line information, and we ran it in LGBT-friendly and print and digital media, LGBT-friendly print and digital media from June to August of 2015 in our major metro areas, so Dallas-Fort Worth, Houston, San Antonio, and Austin. And based on the circulation at the time, there were more than 2.3 million impressions through the length of the media flight. L-Style G-Style magazine, which is a digital magazine out of Austin, they even developed a series of editorials on smoking in LGBT communities, including for youth, to complement the ad, and one even highlighted our outreach activities in those of LGBT Health Link. The L-Style G-Style marketing team said that their readers responded very well to the articles, and the article on youth smoking was shared 154 times on Facebook. And they're very excited to work with us again this year. And we're hoping that this combination of paid and earned media will increase our visibility in the community in a positive way so that everybody knows our quit line services are welcoming and inclusive. And while I'm unable to say for certain that there's a causal relationship between our outreach activities and quit line activity, I will say that there seemed to be a dose-response relationship. In June of 2015, which was the first month of the media flight and the month following the toolkit mail-out and training webinars, we saw a 41% increase in LGBT-identified quit line registrants over the average of the previous 3 months before the intervention. And when we compare the numbers during the month of June 2014 to June 2015, there was a 175% increase in LGBT quit line registrants. Oh, next slide, please. Sorry about that. And we also spurred some sustainable change. Almost immediately following the training webinar we held in May, the medical director for AIDS Arms Incorporated contacted the Tobacco Research and Evaluation team at UT Austin to request technical assistance to integrate e-tobacco protocol into their EMR system. And I'm happy to say that they went live in December 2015 and have been steadily making referrals ever since. At last check, they have referred 83 patients since they went live. Their clinic is a great champion to have on board to encourage other HIV and AIDS clinics to follow suit in Texas. And we were also able to establish valuable working relationships along the way, especially while we were in the information-seeking stage of the planning this intervention. Through my involvement with the Cancer Alliance of Texas, I was able to connect with Liz James, who is the former CEO of the Lesbian Health Initiative in Houston. She was also, luckily, a member of the steering committee of LGBT HealthLink, and so she was able to introduce me to the invaluable resources, both human and digital, that you'll hear about in a few moments, in Texas and through LGBT HealthLink, such as the Empowered Promising Practices for LGBT Tobacco Prevention and Control Guide, and the other fine documents they have published since. And we have also been able to connect with a number of community partners and grow our social capital because of this connection. So this project gave us a chance to strengthen our internal partnerships while at the same time reach out to a high-risk and high-need population that we as in chronic disease programs here in Texas, had little to no experience reaching out to before. And while the results are preliminary, they do seem very promising. So all in all, our Plan B really should have been our Plan A from the beginning because it worked so well. And so we're definitely excited to see what the future of this collaboration brings. So I will turn it back over to Josh now. And I am free for questions at the end. And here's my contact information should you have any questions after the webinar.
Yeah, thank you so much, Jessica. And so, as you mentioned, continuing on this topic, I'd like to turn the floor now over to Donna Solomon-Carter. Donna is the social media and project specialist for LGBT HealthLink at Centerlink, and she looks for innovative health messaging that will encourage LGBT communities to live cancer and tobacco free. So, Donna, the floor is yours. Thank you for joining us.
Thank you, Josh, and good afternoon, everybody. Thank you, Jessica, for providing us with a great example on how states can engage LGBT communities in order to reduce tobacco consumption. No doubt LGBT communities suffer from health disparities, and tobacco use is a shocking one, yet not very well known. The 2012 National Adult Tobacco Survey data found that LGBT people smoke at rates 50% higher than the general population. There are many reasons for this disparity, including stigma, discrimination, where we hang out at bars and clubs, and just coming out are all associated with smoking status among LGBT individuals. These disparities increase even more when you dissect LGBT communities, presenting bisexuals and transgender individuals as ones with even higher prevalence. So where can you find us? Where can you find LGBT communities in your cities or state? First, you can find your local LGBT community centers, and that's accessible through the Centerlink website, where you can search the directory for city, state, or region, our social and support organizations, open door churches, bars and clubs that cater to the LGBT communities, health groups, university groups, programs, and GSAs, Pride events, which are starting just the beginning of June, so you'll be able to have even better access, print media, and social media outlets as well. A little bit more about HealthLink. We link people and LGBT wellness information. We promote adoption of best practices in health departments and community organizations to reduce cancer and tobacco disparities. We are one of 8 CDC-funded cancer and tobacco disparity networks. We build community wellness through training, education, and policy change. Community wellness refers to reducing the burden of chronic disease and cancer in our communities through access to health care, eating better, exercising more, and being tobacco-free. All our offerings are specifically tailored to the local communities and the local needs. Our support is based on the opportunities available locally. We use what others have done and replicate it in different locations across the country. As part of the engagement of the HealthLink Steering Committee, we held a public e-summit in October of 2015 to discuss the issues of importance to HealthLink. Through Centerlink's LGBT Community Center and Steering Committee member, the Lesbian Health Initiative in Houston, we found out about how the Texas Department of Health Services was engaging LGBT communities. We invited Jessica to present on the cancer burden in LGBT communities to provide an overview and basic understanding of health disparities and the cancer burden disproportionately impacting LGBT persons. Jessica presented the infrastructure in Texas to tackle cancer and opportunities for LGBT community engagement. Her presentation is available on our website on our resource page. We have sent the Tobacco Prevention and Control Branch and the Comprehensive Cancer Control Program of the Texas Department of Health Services posters, signs, and other educational materials for display in their offices to share with their colleagues and or to start educating visitors by integrating LGBT images and messaging. HealthLink also included ideas to engage during Pride events. We do this with every state. Texas used our Empowered LGBT Tobacco Prevention Best Practices to implement strategies to reach out and engage LGBT communities. Our future engagement will be to share the work of Jessica and Texas on Facebook, Twitter, and all our additional social media platforms as Jessica goes to conferences and events to discuss her strategies to engage LGBT communities. We will also connect with local LGBT community centers and other LGBT leadership to build relationships in order to expand health programs that include tobacco cessation and cancer screening and to decrease health disparities for healthy LGBT communities and that of your state. We have created original messages and co-branded with existing campaigns. HealthLink encourages local departments of health and community-based organizations and programs to visit our website and fill out an order form. Once we've received your order, one of our fabulous volunteers fills these orders and ships them across the country and around the world. All orders are free of cost to you. We encourage co-branding of the educational materials and to include local content to make it appealing to those you are trying to target. We also encourage departments of health and community-based organizations to join us to support our Healthcare Bill of Rights for LGBT patients and their caregivers. You can visit healthcarebillofrights.org for more details about how to bring confidence to LGBT communities to receive proper, competent health care. We invite you also to look for upcoming Pride materials for distribution at local events and to order them from our website once they become available. Would you like to follow Texas as an example to engage LGBT communities in your city? Here are ways you can contact us and learn more about what we do. Thank you so much for the opportunity.
Thank you so much, Donna, for joining us and providing us some perspective from LGBT HealthLink. Before we move on to our final presentation, I'd like to remind everyone joining us to please utilize the chat box in the lower left corner of your screen for the Q&A session. We'll be happy to take questions, and phone lines and computer lines will be muted today, so you can ask questions through the chat box. And so moving on to our final presentation this afternoon, I'm going to turn it over to Karen Gerard. Karen is the Section Manager of the Health Promotion and Chronic Disease Prevention Section of the Oregon Public Health Division. She received her master's degree from Portland State University in Public Administration and her bachelor's degree from Willamette University in International Studies. She has worked in public health for over 20 years, focusing on tobacco and obesity prevention, and Karen is also a past chair of the Tobacco Control Network. Karen, thank you so much for joining us.
Thank you for having me. I'm here today to talk about the overlap that we are experiencing here in Oregon related to marijuana and tobacco prevention. And some of that overlap has been planned, and other parts of the overlap we've just experienced them and are rolling with it as we go. So I wanted to give you a quick timeline of what's going on in Oregon with marijuana. And on November 4th in 2014, Oregon voters passed ballot measure 91, which legalized retail marijuana. It's called recreational marijuana in the ballot measure, but we refer to it as retail so as to avoid the impression that this is necessarily a positive thing. Following the passage of ballot measure 91, the following legislative session, we had a bill to expand the Indoor Clean Air Act in Oregon to include all inhalants, including herbal hookah, e-cigarettes, and therefore also included marijuana in that definition. And I'll talk more about how integral the marijuana was to that discussion. On July 1st, 2015, the retail marijuana was legalized for possession, and on October 1st, 2015, medical marijuana dispensaries were able to sell retail marijuana. And then on January 1st of this year is when our Indoor Clean Air Act provisions went into effect, which include marijuana. So now what? Now that retail marijuana is legal in Oregon, what does that mean for us here in the Public Health Division? And what I thought I would focus on is what we know about, which is we know what works for tobacco prevention. We know that a sustained funding for a program to address tobacco, the increased marketing, new products, ever-changing market is really important to have people all over the state able to respond to the threats that are there for tobacco. We know that increasing the price of tobacco is an effective policy to reduce tobacco use. And we know that 100% smoke-free policies and tobacco-free policies are integral to keeping people from starting to use tobacco, but also helping people who are trying to quit or stay quit. And access to cessation is also important for tobacco prevention. And hard-hitting media campaigns. Having a counter marketing campaign to the tobacco industry efforts in our state is a really important and very effective way of providing support for all those community programs around the state and trying to work to prevent tobacco use and help tobacco users quit. So I think what I want to stress is that in public health, the tobacco prevention and education program, when marijuana was legalized and folks looked around to see where is this expertise in an effective prevention and education program, the Oregon Tobacco Program has been looked to consistently for how we might address marijuana. They are obviously very different products, and I don't want to conflate the two, but the expertise that we have here in public health on tobacco prevention, having a comprehensive program in place, addressing tobacco from many different angles has been pretty important for the consideration of how to handle marijuana and marijuana prevention. So policy systems and environment change is really important for all chronic disease issues, but we really have years of experience in tobacco control for real success in changing the context that people live within to prevent and reduce tobacco use. And as I said before, some of the efforts that we've done in Oregon related to marijuana and tobacco we were able to capitalize on the legalization of marijuana to affect tobacco prevention strategies in Oregon. And the biggest example of that is the expansion of our Indoor Clean Air Act to include e-cigarettes and all other inhalants that are not FDA approved. So I think that one of the key reasons that House Bill 2546 passed the legislature and was signed by the governor was that Oregon had just experienced the legalization of marijuana, and it became very apparent very quickly that if e-cigarettes and other inhalant delivery systems were not included in the Indoor Clean Air Act, we would have no way of, or enforcement would be extremely difficult for public health and law enforcement. And so marijuana was really, the legalization of marijuana was really key to pushing that conversation forward. The other way that we've really used the legalization of marijuana is to talk about other ways that people are encouraged and to use these products. And we certainly have experience in tobacco control in talking about the role of flavored tobacco, the role of packaging and labeling, and of course youth access. And I wish that I could say that that we've been successful in addressing all of these issues with marijuana, but we haven't. But we have certainly been able to link the way that these products are marketed and available and in our communities as a way of talking about flavored tobacco, age of purchase, and so on. And then, of course, marketing. And if you live in a state that doesn't have legalized marijuana yet, it has been quite shocking to me to see billboards, newspaper advertisements, flyers, all sorts of promotional activities, as was covered in some of the other presentations today, that are really pushing marijuana, flavored marijuana, and all of these different aspects of it. And so it's really been really showed me how different the environment has been for tobacco over the last several years because of restrictions around marketing and advertising, and what it might look like again if those restrictions are not in place. And we're really experiencing that with marijuana. And as I said before, the expertise that we have in public health around key prevention interventions really plays a role in how we might address marijuana. So this is an area that we haven't gone looking for the work, but it's found us. The legislature, with the legalization of marijuana in Oregon, they are very concerned about youth access to marijuana and youth use of marijuana, and allocated funding this past legislative session for a health communication campaign. And again, when they look around and see where is that expertise for developing messages, working with different communities to identify what the key messages are that work, who are the messengers to get that information out into communities, they look to public health, and they look specifically to the Tobacco Prevention and Education Program. So one of the ways our program is changing here in Oregon is the addition of youth marijuana prevention into our health promotion and chronic disease prevention work. And we received a substantial amount of money to do a pilot health communication campaign in Oregon over the next year, with the intention of funding a larger campaign statewide going forward. And I'd like to put that in context. We received almost $4 million for this pilot campaign, media campaign, and that is for the pilot only, and that is about, if we're at full, that's about what we have for our entire tobacco prevention and education budget for a 2-year period. Not budget, but media campaign budget. So that really shows the the context that we're working within and the attention that policymakers are placing on marijuana. And by using our expertise and information that we have, we are working to try to make sure that while we are talking about the dangers of marijuana, we are also linking that to the marketing and flavors and access to tobacco as well. And these are just some of the materials that we had to develop quickly once the law was passed. And again, these are just materials that were developed through extensive focus groups using information campaigns from Colorado and Washington State as well, and just really trying to use our expertise to get this information available and out there quickly. And as we develop this pilot media campaign, we will certainly make that available as well. The other area of expertise that we have in public health is around data. And very quickly, the Tobacco Prevention and Education Program and the section that it sits within has been looked to make sure that we get the right data that we need to collect on marijuana use and exposure to things like advertising and marketing, flavors, etc. And so we got as many questions as we could onto our population-based surveys, as well as we've been doing some panel surveys, and then, as I mentioned before, extensive focus groups with different populations around Oregon. And here you'll see that for 11th graders and 8th graders in Oregon, 19% of 11th graders used marijuana in the past 30 days, and 8th graders it was 9%. This was all before marijuana was legal in Oregon, so we'll be watching these trends carefully over time. And then this I thought was really interesting for us in the way that youth use marijuana. The vast majority of youth who use marijuana smoked it, but edibles and vaporizing it are certainly probably areas that we will see an increase in the next several years. And with that, I'll turn it back over to Joshua.
Yeah, thank you so much, Karen, for your presentation. And thank you again to all of our speakers for joining us this afternoon on the webinar. And I'd like to take a quick opportunity also to thank Barry Sharp, who is the chair of the Tobacco Control Network, who is joining his colleague Jessica over in Austin, Texas, for today's Q&A portion as well. So we now have ample time for questions and answers, and so I'll be moderating the Q&A session and directing inquiries from the chat box to all 5 of the speakers that you just heard from. And I'd like to remind you that phone and computer microphones are still muted, so if you have a follow-up question or a clarifying question for our speakers, please feel free to continue to utilize the chat box for that purpose as we are addressing questions. So the first question comes from a few people joining us this afternoon. It's a logistical question that I'll be able to address. Will there be access to the webinar slides and recording after the webinar today? And the answer to that question is yes. As soon as that is available, there will be a follow-up email coming to all of you who are attending this afternoon with a link to webinar slides and to a webinar recording. And then again, those resources will be posted on the TCN and ASTHO websites in about a couple of weeks. So moving on to other questions, we have one question here for Laura in Minnesota. Laura, has Minnesota been doing any work in Native American communities with menthol or with tobacco control more generally?
Well, I'm pleased to share with you that we have 10 grants devoted exclusively to work in our American Indian tribes in Minnesota, and 2 other grants through our tobacco-free communities funding dedicated to metro American Indian populations. So our philosophy really is to fund tribal and American Indian populations where they're at, and it's a lot of their work is specialized to reflect the traditional views on tobacco. So the funding definitely is not going toward menthol point-of-sale work, but rather kind of letting the tribes define what their needs and the approaches that they want. So extensive funding and work, but not necessarily menthol.
Terrific, Laura. Thank you. We have another question here asked to Beverly. And so, Beverly, what do you think were the biggest factors that allowed a Tobacco 21 law to pass in the state of Hawaii? Hawaii has a Tobacco 21 bill passed statewide. They might have been the first to do so. If you could clarify that for us, Beverly. What do you think made that possible in Hawaii?
I worked on the bill. They were a very cohesive group, an excited coalition that methodically worked through their strategy. I mean, it was one where they had a plan. They stuck to the plan as much as you can in this field of work, but they left enough room that if we had to adjust with the council, if there was something we needed to do there a little bit different, do so. I think the other factor in Hawaii that was critical was the fact that they had talked to partners, but also unlikely partners, and brought them to the table. And I think I mentioned in the presentation, law enforcement was one of the partners. They had youth involved, and they had the college involved. As you can tell, I'm kind of gushing. It was a wonderful experience to work with them because they were the first ones out of the chute on this issue, and they made sure that it was inclusive. And usually tobacco taxes or clean indoor air is not a bipartisan issue, and this particular issue was not only bipartisan, we had unlikely partnerships at the table. So I give a big mahalo to the folks in Hawaii because they did.
Thank you, Beverly. And also, I think your phone line might be cutting in and out a little bit again. So if you could take steps, if possible, and
okay,
so we can hear you more clearly, that would be a big help. Yeah, I really appreciate it. So next up, we have a very long question directed to Donna at LGBT Health Link. Someone is writing that they are the director of a local tobacco control organization, and they have a huge local 2-day Pride event that draws over 14,000 people annually from the region. It's held at a downtown park under a large covered pavilion, and the organizing committee for this event includes many smokers, and the event is very, very smoke-filled. This person is struggling to figure out how to engage the event organizers and reach the community when they don't want their staff to be exposed to high levels of smoke. Donna, do you have any suggestions about how to make Pride events smoke-free?
Thank you, Josh. I appreciate the question, and thank you, Nancy. We have worked with multiple Pride coordinators and event planners in the past year that have been able to successfully present a smoke-free event. And many cities all over the country, Copeland, California, Phoenix was a big one, Florida, Broward County, Florida, where we're located, Idaho, a lot of great success. So I would be happy to connect you with those event planners and the departments of health that worked with them so you can have access to how they made that happen for them.
Terrific, Donna. Thank you. We have another question here for Karen. Based on the work and time it took to pass the new Indoor Clean Air Act regulations, what work do you think states can do or need to do to pass statewide tobacco retail licensing and increase the age of smoking?
Yes, thank you. I think that, well, first of all, Oregon is one of 8 states that does not have a retail license program for tobacco, so that is a major policy area that we're focusing on. But I do think that with legalized marijuana in Oregon, the age of being able to use marijuana is age 21. That is also the age for alcohol. And so that does, I think, provide an opportunity to talk about substances that are dangerous for youth and young adults to use. And it doesn't make any sense to have tobacco be 18 and those other substances be 21. So I am hopeful that legalization of marijuana will help with tobacco 21 in Oregon. I also, as far as retail licensing of tobacco retailers, certainly the discussions that are going on statewide as well as in local communities does include e-cigarette retailers, and I'm really glad that the Indoor Clean Air Act changes that occurred last year included the e-cigarette retailers, and marijuana contributed to that discussion. And I think based on that momentum, talking about, again, marketing, flavors, packaging, labeling, that we will be successful in having tobacco retail licensure in many more Oregon communities and hopefully statewide soon.
Perfect, Karen. Yeah, thank you for your input on that. Next, we have a general question that I think it might be best to ask this individually of all of our presenters. The question is, what steps can health departments take to get executive leadership buy-in on these challenging tobacco control policies? And so we haven't heard yet from Jessica or from Barry in Texas. So Jessica and Barry, how, in your experience, can you get executive leadership buy-in on smoking cessation outreach to the LGBT community?
No, this is Barry. I'll take a stab at this. I think for us, the big thing was we showed the data, and we were able to tell the story of why it was important, what the prevalence rates were, and why, what we were going to do. And that we let the data and the evidence speak for itself to help us get the internal buy-in. And I think finding a way to do it that worked with our existing structures within the agency really helped as far as the methodology we wanted to use, so that it made it very easy for our leadership to really buy into what we were doing, because it was done in a way that would make sense, and a way that would make sense to those who weren't inside the health department also, maybe looking in from the outside, that we were doing the right things, and we were doing it in a way that was do it the right way also.
Terrific, Barry. Thank you. And so staying on this topic, Donna, I know you're not in a state health department, but perhaps you work with LGBT Health Link. Do you have any thoughts on how to engage health department leadership on LGBT outreach for tobacco control?
Well, we do. Our target shareholder, one of our shareholders, are the health department, so we do work very closely with whomever will have us and who requests assistance from us. I think the most effective interaction is to just kind of be right local with the organization who wants to affect change. And we do that by connecting the LGBT centers to their local departments of health, so that they can work together right there, right in their own main street, to make that the cooperative relationship work best.
Thank you, Donna, for that input. And so moving on to Laura, same question for you, Laura. How, in your experience, do you think state health department tobacco control employees would be able to get buy-in from executive leadership if they're working with menthol policy?
I think it's a great question, and it's been a good order because I'd like to build on what Barry and the others have said. So as highlighted in our presentation, we always start with the data, so we clearly define the problem. We move to the research to make sure there's an evidence base and we understand the potential population level impacts. But when it comes to decision makers and policy makers, for some of these issues, and especially in menthol, I think they have to understand the readiness of the community and those impacted. And it's particularly true in menthol because we're talking about a tobacco of choice by specified communities. So one of the first decisions, and it's kind of looking at your landscape, is do you want to do this at the state level? Is there buy-in? Is there readiness? Or do you want to do it at the local? And I think here it's going to be at the local level. And then it requires fairly significant engagement by the community. And that's where we go back to one of our triple aims of health equity, is strengthening the capacity of the community to define their own healthy future. So I think that the local decision maker or state decision maker has to know that the community is engaged and supportive of what's potentially a very significant policy change, so that they know if they make that vote or make that policy change that there's going to be backing for it in the community.
Yeah, great, Laura. Thank you. And so same question to Beverly from Campaign for Tobacco-Free Kids. What should state health departments be doing to get executive leadership on board with Tobacco 21?
Well, I think it's just as important. I agree with what everyone has said about the policies they're talking about. But I think especially with Tobacco 21, it's really important, the educational component of this. It's pretty easy to understand when you look at raising the age to 21, but it's not as easy as changing 18 to 21. So what I have found to be the most effective, to have youth involved that will actually talk to the leadership about the fact that they purchased tobacco from someone that was older. And I think that's one way to go. Depending on certainly your leadership, maybe that's not the way to go, and they're more into the statistical. And they want to see polling information. Well, the polling information that we have from east to west and in between has been from 65% to the mid-70s. And I think that that's really important, just as the previous speaker said, to show that you do have the buy-in, that people want to do this, and also this polling was polling smokers at the same time too. And I think those messages are important to get across. So I'm a firm believer in education. Some of the leadership needs to be educated more than others and more times than others, but I think it's really important to be able to get the youth involved in some real personal stories.
Tremendous. And then same question, wrapping us up to Karen. What should health departments be doing to get executive leadership buy-in in the light of marijuana use or marijuana decriminalization, or perhaps even full legality of retail marijuana?
Well, I think more than anything, it is being able to scan what's going on in your community and have some situational awareness and see where tobacco prevention might be affected by what's going on, on the ballot or other policy decisions. And so we were just very clear early and often about the policy implications of retail marijuana on the tobacco prevention program, specifically with the Indoor Clean Air Act. But also in doing that, that also led other opportunities to the tobacco prevention and education program, just by being they're providing good data, good solid information and evidence, and being ready to think through some of these policy implications carefully with leadership.
Tremendous, Karen. Yeah, thank you, and thank you to all of the speakers for addressing that. We have time for one final question before adjourning today, and in fact, it's not a question, it's a comment. There's a comment suggesting for those interested in the earlier presentations from this afternoon's webinar that there's more information in 2 different resources, and I can also vouch that these resources are very helpful. The first is a report called What Surrounds Us Shapes Us, Making the Environmental Case for Tobacco Control, and that's published by the Berkeley Media Studies Group. And then in addition, there's a really tremendous Robert Wood Johnson Foundation report called A New Way to Talk About the Social Determinants of Health. So that sort of zooms out and talks about social determinants. So thank you, Robin Hobart, for bringing those resources to our attention. And so that will wrap us up for Q&A. And so I'd like to thank everybody for their questions, and thank you to the speakers for providing responses. And so I hope the Q&A was helpful in shedding additional light on these challenging tobacco policy areas that we learned about this afternoon. And so moving on, I would like to remind everyone really quickly to visit the redesigned TCN website and access all the resources available there. On the website, you could submit a Help Your Peers request and receive feedback from TCN members on any tobacco-related question. You can view archived copies of the biweekly TCN newsletter, and you can also view a directory of all Tobacco Control Network members nationwide. This webinar will be made available on the TCN website homepage within the next 2 weeks or so. And if you'd like to join the TCN mailing list, or if you have any questions about the TCN and the website resources, please reach out to us at tcn@astho.org. And then in addition, we invite each of you to share your state success stories with ASTHO. We're currently interviewing states on their work and sharing it with our networks and extended audiences in tobacco control. And as you all know, peer-to-peer learning is really powerful, and so we welcome the opportunity to facilitate this information sharing. And so if your state is doing something amazing in the area of tobacco prevention and control, and I'm sure that's the case for everyone joining us this afternoon, please feel free to contact me directly at jberry, J-B as in boy, E-R-R-Y, @astho.org, and you'll see my email on the final slide here as well. And then finally, I would like to let you all know that the final webinar in what we're calling the TCN Spring Webinar Series will be held on May 25th at a time to be determined shortly. Look out for more details on registering for this webinar, which will feature presentations on how to address disparities in tobacco use by educational attainment. And a registration link for this webinar will be sent directly to you via email as soon as that's available. And so we hope that you'll be able to join us and spread the word to your colleagues. And then as a wrap-up, I would like to let everyone know that as soon as we adjourn in a moment or so, you'll be directed to a survey, and a link to the survey will also be made available to you via follow-up email. Please take a few minutes to complete the survey, as it provides us with useful information for our future projects. And with that, this concludes today's webinar. So I would like to once again take the opportunity to thank Laura Olivan, Beverly May, Jessica Hyde, Donna Solomon Carter, and Karen Gerard for their informative presentations. I would also like to thank everyone from ASTHO and from the Tobacco Control Network who contributed to today's webinar. And as I mentioned earlier, a recording of today's webinar will be sent to you via email, and then it will also be posted on the ASTHO and TCN websites in approximately 2 weeks. And again, any general inquiries that you may have about TCN can be sent directly to tcn@astho.org. So thank you so much for joining us, and enjoy the rest of your day.